evening, everyone. My name is Dr. Soumya. My guide is Dr. Vennam, and my topic is on anesthetic concerns for Montgomery T-tube insertion in case of tracheal stenosis. Introduction: Tracheal stenosis causes airway obstruction, dyspnea, shortness of breath. It causes mainly due to long-term intubation, tracheostomy, benign and malignant tumors, and radiation therapy to neck. Montgomery T-tube has a pivotal role in maintaining airway patency and also helps in phonation and normal breathing through nose. Case reporter, a 25-year-old male diagnosed with tracheal stenosis secondary to intubation, post-poisoning and bronchoscopy done at outside hospital, suggestive of stenosis present in subglottis region with diameter around 4 mm. Tracheostomy was done under local anesthesia with TT size 6.5 mm, and his complaints was difficulty in breathing on exertion and breathlessness at rest. On examination, all vitals are within normal limits and SpO2 is 97% on room air. Investigations on routine blood and urine investigations are within normal limits. Tracheostomy cannula is mounted at D1 level, and MSCT thorax tracheal stenosis for a length of 12 mm at the level of the substernal notch and lower margin of the thyroid lobes at C6 vertebral level. Narrowed segment measures 2 mm in diameter. Video laryngoscopy shows stenosis is minimal just above the tracheostomy. Induction: patient on tracheostomy tube in situ, pre-medication ondansetron 4 mg, glycopyrrolate 0.2 mg and midazolam 1 mg given, circuit connected to the tracheostomy tube. 100% oxygen given, then induction of anesthesia carried out with propofol 100 mg scoring 50 mg given. Intraoperatively, post-induction, patient was hemodynamically stable. Anesthesia was maintained by atracurium 30 mg following direct laryngoscopy was performed by ENT surgeon after induction of anesthesia with tracheostomy tube. Tracheostomy tube was removed and plexometallic tube inserted through stoma for visualization of larynx and post-cricoid space. Anesthesia and ventilation continued through the same. After procedure, the flexometallic tube is removed and portex CT tube is inserted through larynx pulled out through tracheal stoma, and the proximal portion of T-tube is connected to the tip of the portex CT tube and pulled up. The distal tip of the vertical limb of T-tube was inserted back into the trachea through tracheal stoma. After correct placement of T-tube, ET tube was removed and extratracheal limb is connected to the circuit for ventilation. Patient reversed and was on spontaneous ventilation with T-tube breaths. Post-operatively, post-op analgesia was maintained by IV paracetamol and patient maintaining saturation at 98% of room air. Bilateral airway air entry is equal. Phonation present. Patient was hemodynamically stable. And discussion: Montgomery T-tube is made of silicone anodies composed of short laryngeal and long tracheal and extratracheal portions. T-tube size range from 4.5 mm to 16 mm, which are required for tracheostomy insertion. T-tube is mainly used in conditions like post-intubation stenosis, tracheomalacia, and trauma. The other studies used Duman stents for tracheal stenosis, but T-tube is superior to the stents because there is high chance of displacement of stent, and stent can be blocked with secretions. The advantages of the T-tube is it allows easy clearance of secretions by suctioning and reduces the risk of migration compared to the Duman stent. It also allows phonation and normal breathing and through nose and minimal coughing. Conclusions: the T-tube placement is an useful option for tracheal stenosis patients, and it has less tissue reaction and is an effective, safe and well-tolerated method. It significantly improves patient physical quality of life and helps in phonation, and it also reduces the tracheostomy complications. First picture shows the tracheal stenosis which is present subglottic region, and this is the T-tube insertion. Second picture shows, and third picture shows after T-tube insertion.